There's a man walks into a local bar and orders 3 beers, and the bartender brings him the 3 beers. He drinks them, he leaves. Over the next few weeks, he's a regular. He does this a couple times a week. And the bartender finally says, how about if I give you 1 beer at a time? And the man said, no. When I left Ireland a few months ago, my 2 brothers and I promised that whenever we'd have a beer, we'd have 1 beer for each of the brothers. So bartender's like, wow, that is so wonderful. So weeks go on, he's doing the same thing. And then finally, one day comes in and says, I just want 2 beers. And the bartender's, oh my gosh, one of his brothers passed away. So the bartender gets him the 2 beers, goes over and puts his hand on his shoulder. Everything fine? The guy's like, yeah, everything is great. Oh my God, you ordered 2 beers. Your 2 brothers are fine? No one died? He said, no. I ordered 1 for my one brother, another one for my other brother, but I didn't order 1 for myself because I gave up drinking for Lent. So, all right. So we'll start. First off, I'd like to thank Dr. Braheny and the Planning Committee for inviting Dr. Marugg and I to give this conference, this lecture. And actually, let me get in here. All right, we have no conflicts of interest. Actually, I'm no longer the program director. I'm the chairman still, so I kind of oversee the residency program. I stopped being the program director last year after a little health issue that I had. And Dr. Marugg does not have any disclosures other than she's here with me, so she has to speak highly of the program and the like. So it's the only other thing. The learning objectives. First, I want to go over a little bit of the background. Want to give a little bit of the accreditation, kind of a small course in accreditation process for graduate medical education. A little bit about Sisters Hospital, how we do it, how it could be done elsewhere, and then Dr. Marugg is going to go over the perspective. So it's kind of a tag team here. So Sisters Charity Hospital, located in Buffalo, New York. It's part of Catholic Health System. So 4 Catholic hospitals, along with the Diocese of Buffalo, came together in 1998, so 20 years ago, and formed Catholic Health. Sisters Hospital, the oldest hospital in Buffalo, New York, started in 1848, so a very long history. Actually, the first hospital in Buffalo when 6 Sisters of Charity arrived from Baltimore. Helped in the cholera epidemic, established in 1852 an infant asylum and maternity hospital. So Sisters Hospital has a long-standing reputation for caring for women and being involved in obstetrics. I put some pictures because I know everyone gets this impression of snow in Buffalo, and the top picture, actually, if you notice, there's kind of this wall of cloud, and that's actually a lake effect snow band that comes over the lake, takes all the moisture off the lake, and then just dumps snow. 6 inches an hour, sometimes more. And then, a few hours later, it's the bottom picture, we dig out because we have 2 or 3 feet of snow. I mean, people watch sometimes the Bills game, not because of the Bills, because of their team playing the Bills. But, and, you have the big snowstorm, and everyone gets this impression, and it's relatively true, but there is a good part of it. 9 months after a big blizzard like this, we have an uptick in births. We call this SRFP, snow-related family planning. So the background, small-size hospital, but we do a fair amount of women's care. 2,700 GYN surgeries, 3,485 births, a number of twins and triplets. We have a level 3 perinatal center with neonatology, maternal fetal medicine. We do have 3 Acgme approved residency programs. Obstetrics and gynecology is a 4-year program, and then programs in internal medicine and family medicine. And now here's the crash course in Acgme certification. Some people know it. I've lived with it for a number of years, so I think it's important. And I'm going to just read off a couple things for those residents. Residency, and also the physicians, is an essential dimension of the transformation of the medical student to the independent practitioner along the continuum of medical education. It is physically, emotionally, and intellectually demanding. People agree with that? I think so. and it requires longitudinally concentrated effort on the part of the resident. And the Accgme is actually not a government agency. It is a not-for-profit, independent, physician-led organization that monitors the professional educational standards and actually sets those standards of what is involved with resident education. And just the member organizations, the American Board of Medical Specialists, American Medical Association, all contribute members to the Accgme. And just a little bit of the stats of the Accgme. So resident education, a huge undertaking. 11,200 Accgme accredited residency programs and fellowship programs in the United States. This across 180 specialties and subspecialties, 830 sponsoring institutions. There's 135,000 active full-time and part-time residents and fellows. So 1 out of every 7 physicians is a resident. So what is the importance of Accgme accreditation? So in general, if there is ever a problem in the world, you could always come back that the government had a problem. So if we want to blame Accgme on anyone, we could say it's really the government. In 1965, the Social Security Act started funding for graduate medical education. Before that, interns and residents actually would live in the hospital, and they got a small $50 a week stipend. There was not really funding for training residents. But in 1965, there is a Social Security Act came and said, we're going to pay you for training residents because we think resident education is important for the future supply of physicians. And if you ever want to see a convoluted way of how they pay for it, it's that third bullet. It's the percent add-on to every Medicare case is a multiplier which changes by 1 plus the intern to resident to bed ratio raised to the 0.405 power. I love that, how they came up with that, -1. And that is the percent that you need to increase funding. But it does pay for residents. It pays for the program director. It pays for the extra tests they order. It pays for their salaries, conferences, books, all that sort of stuff. And Accgme or AOA certification of a residency program is needed to receive any of this funding. So if you don't finish a residency that is certified by the Accgme or the AOA, you will not be able to become board certified. And today, most hospitals and most insurance companies require board certification in order to get reimbursement or to have hospital privileges. And actually, the AOA a few years ago is no longer going to be accrediting programs. So the Accgme is now going to be the single sole person who accredits residency programs in the United States. And just for those people who aren't involved with medicine or haven't gone through all the physicians and people, it's kind of a long path. Undergraduate medical education, to medical school, to residency and fellowship, and then finally you're in medical practice. And there's multiple numbers of non-government agencies that direct the path. This is what you have to do, whether it's through medical school applications, all the way, and then finally, only on the bottom right, the Federation of State Licensing Boards. That's the only government agency that really gets into the practice of medicine. Most of the time they leave it to our own organizations to come up with this. So Accgme for residency review, Accgme for OBGYN. We have a residency review committee which is made up of all OBGYN physicians, and this program requirement booklet in the bottom right corner is really the Bible for a residency program. It really details every single thing a resident needs to be trained in, educated in, program requirements for the faculty, how many publications you need, every single detail of the residency program. So it's kind of like the Bible, and if you want to maintain an accredited program, you have to follow these 34 pages. Some of the stats for OBGYN, so fairly large specialty, 5,844 approved positions in all 4 years, so it's a 4-year program, so there's about 1,100, is about 12 to 1,300 people per year. 76% are from U.S. medical schools. 82% of the residents are female, and then just some of the other stats. So out of all the residents who graduate every year, there's not a huge amount who want to practice according to their moral and ethical beliefs. So that's what we're going to get a little bit more into now. And then just some of the accreditation process. Getting an accredited program is very difficult. It takes a huge application. You get a site visit, and then over time, once you get accredited, every year you have to submit a lot of data to the Acgme to continue with accreditation. So it's kind of a pretty arduous process to get accreditation. And then once you get accreditation, it's a pretty long process to maintain accreditation. Every year we have to submit data, and then every year we get what's going on. So right now, as of 2018, there's 277 programs in obstetrics and gynecology, 227, the majority have continued accreditation, but if you don't follow the rules, you don't want to fall into the probation or warning category, which are really not good to be in, because you could lose your accreditation, and then when you lose accreditation, you can't train residents anymore. And this is just some of the data that we have to submit every year. So you look at a resident survey, faculty survey, clinical case logs, board review rate, attrition, program changes, and scholarly activity in the program. And then some of the procedure numbers. So residents, at least in obstetrics and gynecology, a lot to learn, but they have to do a lot. So on top, we have all the obstetrical things. On the bottom, all the GYN. There, you'll notice on the bottom right here, abortion, that actually includes any miscarriages, so it's not elective abortions only. But residents do a lot. So there's a lot of training that goes into this, and residents are very busy. So I'll just go over the Sisters Hospital program timeline. We got our initial accreditation in 1947, so we've had a very long program. We had 2 residents per year up until 2006, and we were able to expand that to 3 residents per year, and then up to 4 residents per year in 2013. We did have some accreditation difficulties back in the 80s, actually when Dr. Dixon was partly in the program. We were about to lose accreditation. This was before I came, and losing accreditation, that's once you've lost it, very hard to get it back, and then you don't have a site to train residents. And then we did have one area in 2000 that were placed on probation. The university wanted to merge our program with another program, and we'd lost our Catholic identity, and because of the uproar that went on, we did get placed on probation, but we have since then come off it and have not had that. I'm just going to go over a little bit of my tenure at Sisters Hospital, and we all have stories. I guess, how did you do OBGYN? I always get that. And I remember I was driving in the car, and like everyone else, mostly everyone else, you can't go into OBGYN as a Catholic. You can't. That's the last specialty I'm going to go into. And I was in the car, and a thought came in my head was, if you don't go into OBGYN as a Catholic, there won't be anyone who can in the future. Where are the women going to go to? So I reluctantly decided to go into OBGYN, and trying to find a program, I actually found Sisters Hospital Residency program, and interviewed there because I first did my data search, and before the internet, very hard to find data on anything, but interviewed at many programs. Sisters Hospital is the only program that, wow, they don't do birth control, they don't do sterilizations. I could fly under the radar here. So I talked to my program director who interviewed me, and I told him what I was going to do, and he quizzed me on it, and they said, that's fine, because we don't do any of that stuff here anyway, so we don't care. So it worked out great. So when I finished the program, I wanted to stay to continue on the residency and actually try to attract people in to Buffalo to get training, because it was difficult to find a location where you get training without compromising your ethical and religious beliefs or feeling like you're the lone person isolated. So I became the associate program director in 1995 through 2000. In 2000, actually, because of the probation, the chair said, you're going to be the program director. The program's getting merged, and I'm going to go on vacation, and that was it. And so I'm like, well, I'm program director. I wrote a letter to the dean. We are removing ourselves from the merger, which caused this huge firestorm, uproar. I remember very vividly being called into the dean's office, and the dean just browbeated me. It was just terrible. I had a colleague from the university program with me, and he said, I'm going to ruin you. And I left. I remember calling my wife and saying, look for some other job for me, because we're going to be leaving. I'm going to get pushed out. But I made a last-ditch effort. I thought, all right, trouble. I actually wrote the bishop, wrote the board, talked about, hey, we're going to lose this. And actually, the bishop, I'm not sure what he did, but he intervened. And a week later, the dean called me in and said, I want 2 programs in Buffalo, not 1. I'm like, yeah, that's exactly what I said. But now he said we're going to have 2. So it worked out very well. I'm just very pleased that the bishop really intervened on our program's behalf. So after becoming program director in 2000, I was that until 2017. Actually, for a number of years, we had difficulty in attracting resident applicants to Buffalo. I always said, listen, the stuff you hear about the weather is not true, okay? It's actually wonderful weather here. Somehow they didn't believe it. So for a few years, we had some kind of dry years. We didn't have a lot of applicants coming in. But we kind of got a slow trickle. But perseverance does pay off. After a few years, we did get some residents starting to come in. And then since that time, and actually, I'm not sure if Dr. Pudoff's here, he talked about 17 residents. Last night logged in to my system on the hospital and counted all my residents, and we have 18 Humanae Vitae type residents who came into the program for this. So very good. And now we have 4, and Lindsay is going to go over a little bit of that in a little bit. But Buffalo is a hard sell. I have to say, hard to convince people to come to Buffalo. I remember one, and this is 2 small, quick, funny stories. I remember interviewing one applicant, and I said, why do you want to come to Buffalo? And she was kind of sitting there like cross-armed. My mom said if I went to OBGYN, I had to go to a Catholic resident with nuns. I'm like, okay, we could fit that. We could fit that bill. And that's why she came. It was the only reason she came to Buffalo. And my colleague, Dr. Obst, who some of you know, she tells me the story that when she got the match letter where she's going to end up, and she saw Buffalo, she started to cry. No, not Buffalo. But she met her husband and stayed on, and now is raising her family in Buffalo. So again, Buffalo is not all that bad. And with Marguerite, I have a new line now. In a few years with global warming, this is like the new South Carolina.
My sister went to SUNY Buffalo for medical school, and now she's in Texas.
So, what's the big problem? Problematic family planning is kind of one of the major issues. I'm going to go over this a little bit, and Dr. Marugg is going to go over this, but family planning clarification, this is directly from the RSC for OBGYN. Family planning and contraception, bullet point 4A6D1, these program requirements are like a legal document. You have to know every single bullet point. Programs must provide training or access and the provision of abortions, and this must be part of the planned curriculum. Residents who have religious or moral objections may opt out and must not be required to participate in training or performing induced abortions. Residents must have experience in managing the complications, blah, blah, blah. And then the other part is it really can't be an opt-in, it has to be an opt-out. You have to have it part of the planned curriculum. So that's one of the kind of the hurdles we have to, how do we address that as a Catholic program? So I just want to tell a little bit of the environment, how we try to screen applicants and our rotations. So for the environment, majority of the training is done actually at Sisters Hospital, which is really a blessing. A lot of places, they have their main hospital, but they'll have a few other hospitals you rotate at. So we don't have sterilizations. We don't perform abortion procedures. Our resident clinic does not provide artificial contraception. So it's a really easy environment for someone to come in and practice their moral and ethical beliefs without being compromised. So just from the baseline, it's a very conducive environment, which I think is very important. Our core faculty all committed to the ERDs, which is another extremely important part of the environment, creating kind of a safe environment, a safe space, I should use that now, safe space for our residents. Applicants, I'm very upfront with the applicants because of one applicant who came through who was actually bullet point number 3, but I say the same thing every year. I've done this for the last, we have actually interviews next Wednesday. I'll say the same thing to all the applicants. If you want to be a well-rounded, competent generalist, OBGYN, you'll get great training here. Subspecialist, if that's what you're interested in, it's going to take a little extra effort, but you could do it. If your life goal is to be the director of a Planned Parenthood, this program is not the type you're interested in. And that's because actually one applicant early on said, so what do you see yourself being 10 years from now? And she said, I want to be the director of Planned Parenthood. I'm like, okay. You're not going to get the training you want here. So after about, nice discussion, she didn't come. But again, if that's what their goal is, we're not going to be able to provide that. And but if their goal is really well-rounded, general, competent OBGYN, again, we have a great program for that. Our rotations are family planning rotation, which is required. So the way we have it, and Dr. Marugg is going to go over this in a little bit more detail, we do have 2 days where they're in the fertility care center, 2 days where at their neighborhood health center, and the goal of the rotation is an opportunity to become more familiar with family planning that's not provided by Sisters Hospital, and residents can opt out, and we just basically pluck this right from the ACGME requirements, just so this is exactly what the rotation is, just what you want it to be. But again, Dr. Marugg is going to go over a little bit this more. Some obstacles that I found through the years of having residents contact me, and Dr. Marugg is going to go over this. There's some philosophical obstacles. If the program director or faculty are not supportive, it's always going to be very hard. And even what I found was even the program director or some faculty is supportive, it's really in the day-to-day operations where it gets very difficult. So, and sometimes it's the residents. Residents will say to applicants coming through, oh, don't come here. We don't want you here. We don't want to do the extra work. We want you to just pitch in. Could be environment, and mostly it's the environment. Sterilizations are so common at most hospitals, it's just not even a thought that anyone would refuse to do a sterilization, and probably 35-40% of all C-sections are going to have a tubal ligation part of it. So if a resident has to step aside every single C-section tubal, or if they're the chief and they're the ones who are going to be doing the whole procedure, I mean, it really gets to be very logistically challenging for people. And then there's the feeling of isolation. So how can it work elsewhere? And again, when I have residents come through, because they always interview at Sisters, they always interview here in St. Louis. So this is our competition, which is very difficult because, again, Buffalo versus St. Louis. But devil's in the details. People interview all over the place, and I tell you, you have to be upfront. Getting into a place and then after you've already matched to tell them, oh, you know what, I am not going to do certain things. I'm only going to practice fertility awareness-based methods. Is not going to come off well, because in training, it's already very difficult. Physically, emotionally, mentally challenging to go through 4 years of 70 to 80 hours every week. So it's very challenging just in and of itself to gain all the knowledge base and to have that extra burden of trying to battle your faculty members day in and day out is very hard. So tell them to be upfront, but to really get into the details with how exactly the program is going to accommodate you. Because on Tuesday mornings, with the sterilization time in the OR, and every second year resident has to go through this rotation, it gets very hard because, well, the program has to think, now we have to rearrange the schedule. So be upfront and really work out those details beforehand. Because you can design a program which is acceptable by the RSC to have a kind of a Catholic track if you want. This is a special, flexible experience for this one resident who goes through, and they don't have to go to the year at the secular hospital down the road that does all the abortions and all the sterilizations, and that's where the residents get all their training. You could develop a single track for a resident that they avoid that rotation. But again, that has to all be worked out prior to them coming to have the best impact. And then I'm going to pass this over to Dr. Marugg.
All right. Just a second. So thank you, Dr. Pivuras. It's great to be here with all of you and to talk about my experiences as a resident and a little bit more of the nuts and bolts of how our residency program works and kind of how my experiences being on the student board for the CMA and how I've worked with other residents who've had issues in the past, and I can kind of speak to some of that as well on other programs to some extent too. All right, so the biggest difference I really see in the Sisters of Charity program for OBGYN and other programs is that this is not just a residency program that rotates through a Catholic hospital. It's actually a program that's set up as the Catholic track being the default. And I think that's really what makes it different in that way. And that's thanks to Dr. Pivuras and all of his work in making that a mission and having, we have 277 OBGYN programs in the country, and I really think we're allowed to have one that is openly friendly to Catholics. There are lots of other great programs you've heard about, Mercy, St. Louis, Peoria as well in Illinois, who have kind of crafted a Catholic track that you can opt into if you tell them in advance that, this is why I would be coming here. And I think that's really important to let them know that when you're there, but they have those things worked out. And I also truly believe that any of those 277 programs should be able to accommodate a Catholic resident. They just might not know that they can. So if there's ever any questions about that, those are things that residency programs can and should be able to develop for any resident coming through. So then, there's also how do you handle all of these issues? So that's really, I think, the nuts and bolts of what medical students and then becoming residents are concerned about. How is this program going to handle all of these things and my conscience objection to those? In the Sisters of Charity program, I also was able to fly under the radar. Didn't have to let anyone know really that I wasn't going to do these things, prescribe contraception, participate in referrals for IVF, tubal ligations, those things. So that was a true blessing to me. As a medical student, I never thought that I would have that much freedom to decide when and where I wanted to talk to my peers, my attendings about my religious beliefs. And so that's been really great for me. But, that's also not to say that there aren't things that do come up. To put it simply, our program in working within a Catholic hospital mostly simply follows the ERDs. So I think that's the easiest way to say it. Those things that were listed on the last slide are really only a small percentage of what OBGYNs actually do on a day-to-day basis. Now that's not to say that they don't come up in lots of different situations. So you might have a patient who has had a tubal ligation in the past, and that's something that's very important in her history and that I need to know. Or also if the pregnancy was conceived by IVF, I need to know That and what it puts her at risk for as well. So you need to be very well versed as an OBGYN in all of these things. But it's a small percentage of what you would actually need to do. So I think that that's an important part to recognize. These are not things that I ever shy away from talking about with my patients, or ever shy away from the literature or what I can learn about them, because these are experiences that women are having that are coming to me, and that's very important. But I also will remind them that here we don't do those things. So, for example, a woman might come in to deliver her baby, and for the most part knows that we don't prescribe contraception postpartum. Someone might ask me about it, and I'll simply say, this isn't something that we do here because we're a Catholic hospital. And most people are very, oh, right, that's right, I remember. I heard that before. But sometimes it's a little bit more of a conversation. It's a little bit more education that we do. I, again, am always willing to talk with people about all of these things because I want to be able to tell them the risks of contraception, as well as the benefits. And I don't know that every OBGYN is really willing to go into all of the risks with patients. So I think it's important for us to be as well versed as we can in all of these methods, and knowing how we can talk to patients. I think that's a very important part, whether you're family medicine or OBGYN or anyone who does primary care, because patients know about these things, and if we can really speak to them as educated physicians that aren't ignoring that these things exist, I think that's really, really important to help reach more people. So the other thing that we appeal to at our hospital is conscience objection. I think it's important to go over that from an OBGYN standpoint. So the appeal to conscience is in refusing to do acts that threaten a person's sense of integrity. Patients, as well as physicians and nurses, appeal to conscience in refusing treatment or procedure. But I think it's also worth mentioning that not everyone would agree that that can always be, that you can always use that. So the American College of Obstetricians and Gynecologists, which is really a pretty important body in the OBGYN world, did release a committee opinion called The Limits of Conscientious Refusal in Reproductive Medicine. And they said in that, physicians have a duty to refer patients in a timely manner to another provider. In an emergency where a referral is not possible or might negatively impact a patient's physical or mental health, providers have an obligation to provide medically indicated and requested care. Now, none of that is backed by the legal system or anything like that in our country, but there are those out there who disagree that we can really have a true right to conscience objection as OBGYNs. So I think that it's important that we all recognize that too. So then I actually, when I interviewed in Buffalo, it was the first week of December, and it was 70 degrees outside and sunny. So I was tricked maybe a little bit. They told me it's always like this. And but really the weather hasn't been as bad as I expected. So I want to talk a little bit more about how we handle a couple of the outside rotations that are outside of our hospital, and what that means to us as residents and what it means to me as a Catholic resident as well. So one of the rotations that we do during our third year, we spend 2 months doing reproductive endocrinology. We are not blessed enough to have a NAPRO surgeon in our area. So but we are blessed to have an REI doctor who does look for underlying conditions and works to treat those. So 2 days a week during that rotation, we spend entirely in the OR with that physician. He does myomectomies, he does tubal reversals, endometriosis surgery, he is a very good surgeon that we're able to learn from quite often. So I think that that's a huge advantage that we have. And then 3 of the days of the week we spend in the office, and we learn hormone profiles, the infertility workup, how to do pelvic ultrasounds to look for abnormalities. The part where it differs for some students is that they do offer IVF in that clinic. So that's the point where, as a Catholic resident, you just let them know in their office, this isn't something that I want to participate in. And they don't have residents there year round, so they're never counting on us. They're never surprised when that happened. They've had 18 residents come through that have opted out of that part of the rotation. So I think having those relationships and that support, both from the faculty who have made this possible and known, as well as those attendings that understand that there will be Catholics coming through, have made that a pretty easy process for us. So then there's the family planning rotation, which has been mentioned as well by Dr. Pivuras. So I think we're incredibly blessed to have 2 days a week for that entire rotation that are set aside to working with our fertility care practitioners. So they've developed a program where they have, first of all, they give us the Creighton manual before we even start the rotation. And then they have developed PowerPoints specifically for teaching us, the residents, what's helpful for us to know going through the rotation. And then we go to an intro session. We participate and shadow in multiple follow-ups throughout the weeks that we're there. So I think that exposure is really quite unique, because as even a medical consultant, you really don't have the time to sit and see what the wonderful work that all the educators are doing with all of those follow-ups. So I think to have time set aside specifically to see what that looks like from an education standpoint is really helpful. And every resident does that, regardless of their religious affiliation or belief system. The other side of that rotation is we spend about 3 days a week at one of our local federally qualified health centers, where some of the private docs that practice at our hospital deliver. So we go there. That was actually the first time in the entire residency, which I was 5 months in when that happened, where I had to come out as a Catholic. The attending there on my first day asked me, what is your plan for this rotation? Or, are you planning to prescribe contraception in the future? And I simply said, oh, no, I'm not. I'm Catholic. And she goes, oh, that's great to know. Thank you for telling me and not just hiding it, because there's so much more I can teach you now. I can work with you on different things. I'm not going to waste my time teaching you about contraception, because it's not something that you're going to have in your practice. So thank you for letting me know that. And so I did a ton of annual visits with postmenopausal women, which is a population that we don't typically see as often in our clinic. And she let me go in and take out IUDs and learn how to take out Nexplanons, which I thought was great. I'd love to be able to do that for my patients if they come in and they want those things taken out. I don't want to have to send them back to Planned Parenthood. But I think that's a skill that you might not necessarily think about that you can get experience with if you look for those opportunities. So then the other thing I want to talk about from a resident perspective is, what about those residents that aren't Catholic? So we currently have four residents per year, so a total of 16 throughout the 4 years, and who are Catholic and are there specifically because they're Catholic and they want to have a supportive environment and to practice throughout residency, how they're going to be practicing as attendings. But that means that there are 12 of the 16 that aren't Catholic, and I think it's my job at the resident dinner to make sure that they know as well that this is more or less a Catholic program, and that if they're looking to do a lot of tubal ligations or things like that, this just simply isn't the program for them. And I take that approach because I really appreciated when I was on interviews when residents would say, oh yeah, we have a required rotation at Planned Parenthood. And that, would tell me this really isn't a good fit for me. It was helpful to know that. It's not just having some of that disclosure where even if it wasn't really required, that was the impression the residents had. So getting that resident perspective on where the program is really important. And so I'm also always looking for the Catholic applicants that are there that we haven't found in some of these bigger groups that maybe don't have the support So I think sometimes I'll mention things like, I'll just throw the word NAPRO out there, and sometimes you'll see these applicants' eyes just light up like, oh, this is the person I want to talk to, because they don't know necessarily who the 4 of the 16 are that are Catholic, or even if there's any that are in the program at the time. So finding, buzzwords to let the applicants know that, I'm a safe place, come to me. And then I also think that throughout the residency program, there are difficult scenarios that rise in OBGYN, and that can be anything really along the lines of the example that comes most fresh in my mind is when you have the water breaks at 20 weeks or 21 weeks or something like that, where it's a very difficult situation. And I think having just really good communication with those residents that both are Catholic and that aren't Catholic on, is what we're doing here today because we're a Catholic institution, or is this something that they would do at other institutions as well? I think that keeping that communication line open and really being transparent in what you're doing and whether or not it's a Catholic thing or if it's not a Catholic thing is really important. That helps to shape how residents, especially ones that aren't Catholic, come to understand a Catholic system. And a lot of times they see it as, then we can describe it as good medicine, not just a Catholic thing. So I think that's really important when you have those hard ethical cases, that you're letting people know, what is driving some of our decision making here, and definitely letting them know when it's not the Catholic part. You can't always blame it on that. So I think that's really important. Also having consistency amongst the decisions that are made. So having all of our core faculty that are well versed and on board with the ethical and religious directives is really, really important. Because if you have an attending that's saying, well, we're doing this because it's Catholic and we're here and it's terrible and that's not what we really should be doing, that's totally counterproductive to the entire conversation. And I really think we do have a core faculty that supports that. And I think that makes a big difference as well for our non-Catholic residents who are trying to understand what's happening. And then also just having mutual respect for their beliefs. So what I hope from them is that they'll respect my belief system and and I want to do the same thing for them. I'm never going to tell them you're a bad person because you want to do tubal ligations later on. That's not my goal at all. But I also just want to welcome them and show them that this is a very viable option for an OBGYN, and we're not all crazy, although some people might think that we are. Oops, wrong way. So then the last part that I want to talk about is the mentoring piece. So I know that so many of you are mentors to students and residents and young attendings, and that's just such an important piece. I don't think that we would have 17 from Mercy and 18 from sisters that are coming out as OBGYNs that want to practice in accord with their Catholic faith without so many of you who've gone before us and then are happy, not only happy physicians, but have thriving practices that would really be so encouraging to us moving forward and telling us that this is possible. So my own story, a lot of people also ask me if I always knew I wanted to do OBGYN or if this is something that came up later down the road or what happened. And so for me, I think if you'd asked me in high school or college even what I wanted to do, I would say I love women's health. It's amazing, but I would never be able to do it because I'm Catholic. Very similar. And I think the turning point for me came my third year of undergrad. I had somehow gotten a hold of a Catholic OBGYN who had offered for me to come shadow him for a week. So I was there on my spring break. It was amazing. We spent time in his office. We did surgeries. We did deliveries. And at the end of the week, he called me into his office and he said, so it's the end of the week. What do you think? Do you think even just medicine in general, do you think it's right for you? And I said, this was awesome, but by 10 years, by the time I'm done with my training, you'll be forced to do abortions and provide contraception, and I'm a Catholic, so that's just not what I want to do. What you do is amazing, but I don't think that this will still be here in 10 years. And I very distinctly remember him looking across the table at me and saying, oh, Lindsay, you're doubting the God that moves mountains. So, and if you're right, in 10 or 20 years, if no one else goes into OBGYN who's Catholic, there won't be any left. But if this is something you're called to, God will keep paving the way for you, really. And that's exactly what's happened. I've been blessed with great mentors. I got involved in the CMA from the very first boot camp that they've had, if you know what that is. And really had great people who've encouraged me every step of the way to keep moving forward, and who've shown me that this is absolutely possible to be a Catholic OBGYN, despite what maybe some non-Catholics might say along the way. But thank you to all of you who are mentors to us as students and now residents, and moving forward. That piece is so important, and you don't have to be an OBGYN or even family medicine to be supportive. My two main supports in med school were a radiologist and a pediatrician, so it really doesn't matter. Just having those people in your life who are close by to you, who are practicing Catholics, really makes a huge difference for those students and residents, because a lot of times you do feel like you're the only one, or you're alone in that. So thank you for all you do, and please continue to support those medical students and residents on their journeys.